Hello, everyone, and welcome. I'm Shelley Gunther, Clinical Marketing Manager at Clarius. Thanks for joining us today for another content-rich webinar with renowned emergency physician and educator, Dr. Tom Cook. You're among over 2,400 clinicians who registered for today's popular event. As a cardiac sonographer, today's topic is near and dear to my heart. It's titled Cardiac POCUS, Coronary Artery Disease for the Non-Cardiologist. Now, we all know that chest pain is one of the most common emergency department complaints, and that there's a wide differential diagnosis list. Ischemic heart disease is on that list. So how can we take advantage of POCUS to expedite care when needed? Structural abnormalities can appear within seconds from the onset of myocardial ischemia. So identifying wall motion abnormalities in patients presenting with chest pain or suspected acute coronary syndrome could lead to earlier intervention. Now, in a moment, Dr. Cook will share some cardiac POCUS techniques for evaluating left ventricular function and wall motion abnormalities. And today, we'll be showcasing the Clarius PAL HD3, our wireless high-definition scanner that fuses both a phased and linear array on one head. Following the presentation, I'll do some live scanning and show you some great cardiac imaging using the phased array part of the Clarius PAL, and it'll really show off its versatility for acute care, so please stay tuned. Now, you can use the questions icon at any time during today's session to ask questions, and Dr. Cook will address them following the presentation. I'll be your host for today's webinar, and we'll introduce Dr. Cook in just a moment. But before that, I'd like to share a couple of studies, both from the American Journal of Emergency Medicine, that speak to just how useful and effective cardiac POCUS in the emergency department can be. Now, this study from 2019 set out to assess whether or not emergency physicians with basic training in emergency echo were also able to identify wall motion abnormalities in the left ventricle. This is something not typically evaluated in point-of-care echocardiograms. The residents in the study evaluated patients admitted with ST elevation myocardial infarction. And we know that regional wall motion abnormalities can appear within seconds from the onset of ischemia. And their results confirmed that ER physicians can indeed accurately identify regional wall motion abnormalities. Now, the second paper addresses OOMI, or electrocardiographically occult occlusive myocardial infarction. Now, there's often delayed diagnosis in patients who present to the emergency department with non-ST elevation, which we know results in higher morbidity. And cardiac POCUS can often visualize wall motion abnormalities, which can decrease the time it takes to get these patients to the cardiac cath lab. It was a significant difference in the times from the emergency department arrival to revascularization. It was 673 minutes was the mean, and 432 minutes among patients with wall motion abnormalities seen with ultrasound, compared to 2,158 minutes for those without wall motion abnormalities. So that's a pretty significant difference. Now, just before we get started, I'd like to put out a couple of polls here just to get to know our audience a little bit better. Now, how frequently do you use ultrasound on patients who present with symptoms of acute coronary syndrome? Are you just learning how to do this today, or are you using it on a regular basis? And we'll close the poll out in 3, 2, 1. Great. So a lot of you are just learning today. Dr. Cook's got some great examples of normal compared to abnormal. So I think this will be really good starting point for you. And just a second poll, this is kind of more for my information. I'd like to know, if you perform cardiac POCUS, how are you estimating left ventricular ejection fraction? Are you just using an eyeball method or measuring fractional shortening with 2D or M mode? Are you using AI? So again, I'll give this just a couple of more seconds. 3, 2, 1. Excellent. All right, good. Thank you. Thank you for that, everybody. So let's get on with our webinar and meet our guest speaker. Emergency physician Tom Cook is joining us from Columbia, South Carolina. He trained in emergency medicine residency at Fort Hood, Texas, before taking on a rugged 3-year tour at Tripler Army Medical Center in Honolulu. And after leaving the Army, he joined the emergency department staff at Palmetto Health, where he initially developed the emergency ultrasound curriculum, and then founded the nationally recognized Third Rock ultrasound and the emergency ultrasound course. And in 2001, he became program director. So as you can see, he's fairly passionate about ultrasound and POCUS. Dr. Cook, I will hand the mic over to you.
Shelley, thanks a lot. Nice introduction. I hope I can live up to the hype.
Welcome back.
We'll see if I can live up to that hype. Thanks for everybody who tuned in. If you've seen me before, my condolences. I'll try not to be as bad as the last time. We'll do our best here. But this is a great topic. I haven't given this lecture in a long time, and I forgot how really interesting the material is, and I'll try and do it justice. So at the end of the webinar, I want to make the point that we are going to talk a little bit about a live event that we have coming up pretty soon, and that'll be in Charleston, South Carolina. I'm going to give you some more information about that, and hopefully some of you will be interested in attending with us. But what we're going to try and do here in 45 minutes is talk about coronary artery disease, but seriously, we're just going to scratch the surface here. You could do a weekend seminar on this. There's all sorts of cool technologies in ultrasound looking at wall motion abnormality, and we're just trying to give you the basics here. But even the basics are going to give you a lot of information so that you can have a lot of fun looking for different disease pathologies related to coronary artery disease. And, why should we learn this? Well, certainly if you're in the emergency department, you have a lot of people with acute complaints that relate to coronary artery disease, but you also have patients with chronic complaints, whether it's left or right ventricular failure. They can be related to coronary artery disease. And you don't actually have to be, in the emergency department per se. There are other reasons that you'd want to, sort of get good at this. Preoperative evaluation, maybe just an EKG alone is not sufficient, particularly if there are any abnormalities. You want to look with ultrasound. And also as a healthcare screening, you're a family practitioner, you're an internist who's looking, who has an office or an outpatient-based practice. You might want to be looking at your patients at different milestones of their life just to see what their cardiac function looks like and if there's any evidence of coronary artery disease. So, it's not just about the emergency department. It's about really anybody who's doing clinical care for adults. This can be really a useful tool to have. Now, in terms of how we're set up, what we're going to do is talk about anatomy of the heart, specifically coronary artery anatomy. Then we'll also look at the blood supply as it relates to different areas of the left ventricle and the right ventricle. And finally, we'll do some cases to sort of demonstrate how we use all the information that we're going to talk about today. So if we're looking at the front of the heart, of course, we can see the four chambers of the heart and the great vessels, but we're going to pay particular attention to the coronary artery. So the left coronary artery will come out and bifurcate into the left anterior descending and the circumflex, and the right coronary artery comes out and winds around to the back of the heart. This is the back view of the heart with the four chambers as well as the great vessels. And the circumflex artery comes around here and extends down towards the apex of the heart. The right coronary artery comes around to the back and then gives off the posterior descending artery in about 85% of patients. We also need to mention that the coronary sinus is back here. This is the opposite of the coronary arteries. This is what drains the myocardium back into the right atrium. Now, I mentioned about the posterior descending artery, and in 85% of people, it comes off the right coronary artery, but in about 15%, in 1/6 patients, it's going to come off the left coronary. So if they have obstructive disease of the left coronary artery or the circumflex, they typically have more serious problems because they're knocking out a bigger chunk of their myocardium than if it comes off the right side. So which coronary arteries supply blood to the different walls of the heart? And we're going to start this by looking at apical views. Apical views tend to give us a ton of information. And the idea is we're looking from the apex of the heart towards the base of the heart. So the transducer's on the apex of the heart, and the ultrasound signal moves its way towards the base of the heart. We're going to place our transducer at the junction of the inframammillary line and the nipple line. And that is our target where we're going to place our transducer. And when we do that, the transducer will be sitting on the apex of the heart, and thus the ultrasound signal will be moving towards the base of the heart as we see here. Now, here we see this example. Right here is the inframammillary line. Here's the nipple line. There's our transducer, and we're going to angle that signal towards the right shoulder. That's going to take it through the ventricles into the atrium towards the base of the heart. And we're going to start off with a marker pointing to the left. This is going to get our apical four-chamber view, which is something most of you are probably already familiar with. And here you can see in diagrammatic form where the signal's coming out, the marker's pointed to the patient's left, and the signal's going to go through all 4 chambers, hence the apical 4. Now, what's nice about all the different apical views that we're going to talk about here shortly is it allows us to see every single wall of the left ventricle, and that's important for us being able to discern which coronary artery may have disease. So we'll start again with the apical 4-chamber view, and when we do this, we can see that that ultrasound signal goes through the lateral wall of the left ventricle, through the septum of the left ventricle, as well as the right ventricle and the free wall of the right ventricle. And here we can see on the right side of the screen a very typical apical 4-chamber view. This is a normal heart. And then diagrammatically on the left, we can see which coronary arteries supply which parts of the left ventricular wall as well as the right ventricle. So as an example, the left anterior descending in yellow covers the apical component of the septum as well as the apex of the heart. The circumflex in blue covers the lateral wall of the left ventricle. The right coronary artery in green covers the free wall of the right ventricle. And the posterior descending artery, which comes usually off the right coronary, just picks up this little basilar segment of the interventricular septum. And I call it the basilar segment because it's more towards the base as opposed to the apical segment of the septum, which of course is more towards the more towards the apex. Now, we have that transducer pointed to the left for an apical 4-chamber view, but we have to discuss 2 more apical views. The first one is the two-chamber apical view, where we take the transducer, we're going to rotate it about 40 degrees counterclockwise. So the marker is now really sort of pointed at the head. And then we'll talk about an apical 3-chamber view. We're going to take it and rotate an additional 30 degrees counterclockwise. So now the marker on the transducer will point towards the patient's right shoulder or the base of the heart. So if we start with the apical 2-chamber view, now the signal is going to go through the anterior wall of the left ventricle and the inferior wall of the left ventricle. And you can see that diagram over here. It will give us an image that we see here on the right side of the screen. So here, obviously, the left ventricle, here's the right ventricle. This is the anterior wall right here of the left ventricle, and this is the inferior wall of the left ventricle. Now, of course, we see the apex here, and we can see that the corresponding coronary artery flow comes for the left anterior descending is going to cover the apex and the anterior wall, and the posterior descending right here is going to cover the inferior wall. So that is the apical 2-chamber view. Now we move to the apical 3-chamber view. We're just going to rotate that transducer, maybe about an additional 30 degrees, and now it's going to go through a component or part of the septum, the interventricular septum, and it's going to go through the posterior wall, and we'll pick up a little bit of the right ventricle as well. So when we look at it, this is the view we get. This is now left ventricle, so it's on the other side of the screen from the apical 4-chamber. We see a piece of the right ventricle here. Notice the big floppy valve. There's the mitral valve there, and there's the anterior leaflet, and this is the aortic valve here, the aortic outflow tract. And we look at blood flow, we can see right now that this is now the posterior wall, so it comes from the posterior descending artery. The apex and the apical component of the septum come from the left anterior descending. This little basilar section here is still going to come from the posterior descending, and then the right ventricular free wall is going to come from the right coronary artery. So that is the apical 3-chamber view and the apical 2-chamber view. Now we can also look at look for regional wall motion abnormalities by just using some of the more common things that everybody probably uses, which is the parasternal long axis view or Plaque's view. And when we do it, this, of course, is the image we see with the right ventricle at top, and here's the left ventricle here, the mitral valve, and so forth. And we can see here that this is now a posterior wall, so this is going to be the posterior descending artery. The apex, which is slightly out of view, is here and extends down into the septum to about right here. That's the left anterior descending. This little component is going to be the posterior descending artery, the basilar segment of the interventricular septum, and then the right coronary artery is going to cover the free wall of the right ventricle. We can also use the parasternal short axis view. And so when we look at it here, here's the interventricular septum. That's covered by the left anterior descending, extending around into the anterior wall. Then on this side here, we have the lateral wall of the left ventricle, so that's the circumflex. And then down here, we have the posterior inferior walls, and so those are covered by the posterior descending arteries. So but short axis can also be very beneficial, because usually what you do is we just look at the center, and we see do all these, all the different areas of the left ventricular wall move towards the center, and that's a very common thing to do and gives you a lot of information. Now, what does normal heart muscle look like when it contracts? Well, it looks like pretty much all muscles when they contract. So when a muscle contracts, it's going to do two things. It's going to get shorter and it's going to get thicker or fatter. So we really want to focus on these areas of the left ventricle and to some extent the right ventricle, but mostly left ventricle. And we're going to look to see if the myocardium is getting shorter and thicker as it goes through the cardiac cycle. And here's an example looking at the intraventricular septum in a normal patient on the left. You can see the entire septum gets shorter and thicker as the patient goes, as the heart goes in and out of systole. But on the right side of the screen, this is a sick heart. This is a bad heart. There's been an infarction at some point. It's all thinned out. We don't have really any contraction here. We have some in the basilar piece down here, but this part doesn't contract anymore. And this is somebody who's had a septal MI. All right. I've armed you with some information. Let's apply to some cases and see if we can figure out what's going on. Where's the problem? So this is a case I probably saw 10 years ago. It really stuck in my head because it was a 21-year-old guy who came in with chest pain. He was very dramatic. There was a lot of eye rolling, like what's going on with this guy? And we got his vital signs and said, well, wait a minute. He's tachycardic and hypotensive. And so the thought was, man, this guy might have a pulmonary embolism. And we've had this talk before in different webinars with me. And so my immediate thought was, hey, let me go get an ultrasound and take a look and see what's going on. So this is his parasternal long axis view. And I'll just have you look at it for a second. It's pretty impressive. There's a lot seemingly going on there. But if we really start to evaluate it closely, we sort of see that right in here, we do not get a lot of axial contraction. We don't get a lot of fractional shortening here. And this is something we talked about in our lecture on left ventricular function. But there's something that just doesn't quite seem right there. So if we take it and compare it to a normal heart, and we just look at that axial dimension right here towards the apex of the heart, we see in the normal heart that this gets shorter, and we see over here, we don't really have a lot of change at all. This is pretty much the same. We see some contractility here in the basilar component of the septum, but maybe not so much there. So with that in mind, let's compare that to the blood flow. And we can see that it's the left anterior descending that's really supplying the blood flow to the area of the heart that's not moving so well. What do we see when we look at the parasternal short axis? Well, once again, we have a lot of contractility in the lateral, inferior, and posterior walls, but not so much in the septum and anterior wall. And this is really evident when we compare it to a normal short axis, parasternal short axis right here, where you have a lot of contractility here, and over here we just don't have any at all. And so when we go back again to the blood supply to the various areas of the heart in the short axis, we see once again, this lines up with left anterior descending. How about the apical four-chamber view? What we see is the right heart appears to be pretty normal, no real evidence of right heart failure, but the left ventricle is enlarged. And once again, we're not getting a whole bunch of contractility here at the apex at all, and really in the axial component of the septum as well. And this is even more obvious when we look at the left ventricle in a normal patient. The left ventricle really should be shaped like a cone or a bullet. It should be sort of narrow at the end. And this thing here sort of balloons out, and that's a tip off that the apex is not working very well. And when we look at our distribution of blood flow in the apical four, we once again, we see it lines up with the left anterior descending artery. Now, at this point, we had to say, this guy didn't have a PE. His right ventricle or his right heart looks fine. At least if he has one, it's a small one. So we actually did this backwards. Now we got the EKG after all this was done. And of course, we can see that it's tachycardic. We can see there's P's before Q's. So this is a sinus rhythm. It's regular. It doesn't look like he has a prolonged QT. He's got a normal axis. But boy, does he have some issues with his ST segments. They're all over the place. And this is a STEMI. So we went back to this guy and said, how long you had this pain? And he says, about 2 days. I was like, why'd you wait so long? And he says, well, I was throwing up so bad, I was too weak to get out of bed and come to the hospital. I thought I had just gotten into something and was just throwing up a lot. You know, and why would a 21-year-old think he's having a heart attack? That's not something you see all the time. But that's what happened with this guy. And we subsequently took him to cath, and he had a complete obstruction of his LAD. He had no other coronary artery disease. And so he walked out with an EF of about 30 to 35%, with normal being 60. So that was a pretty dramatic case. And very, very unusual. It did not work out the way we wanted to in him because he had completed his MI by the time he came to see us. Our next case is a really strange case, just like the first one. It's very rare to see a 21-year-old with an anterior MI. This is an old guy who's dizzy. Now, we never probably see dizziness or lightheaded. It's very unusual, but we're going to talk about this case anyway. And he comes and says, I'm just very lightheaded. We get his vital signs and they're normal. So, it's like we always do with older patients when they say they're dizzy or lightheaded, we get an EKG in this guy, and he's got a rate of about 80. He's got P's before Q's. So he's in sinus. His PR interval's normal. His QRS interval's normal. It doesn't look like he has a prolonged QT. He's got a normal axis. He's up in 1 in AVR. I don't see any ST or T wave stuff going over here, but he does have some Q waves in his inferior leads. Now, remember, this guy does not have chest pain or shortness of breath. He just says, I'm a little dizzy. He's a little verklempt. That's about all he's saying to us. And so, we're kind of thinking, well, does this guy have some coronary artery disease in the past? And maybe now we should take a look at him. Of course, we're going to take a look at him with ultrasound. This is an ultrasound lecture. That's what we're going to do. Yeah. So, of course, we get a whole bunch of blood tests here, and we get a trope and a BNP. They're all normal. Should we be worried? Yeah, we should be worried. He's got an abnormal EKG. So here's his apical 4-chamber view. And we're just looking at this left ventricle. Man, that is a lovely looking left ventricle. I would take that one. Look at this one right here. Nice, beautiful septum contracting. The apex contracts down. The lateral wall contracts down. Don't see anything really wrong with that at all. Then we're going to move over to the apical 3-chamber view. Okay. So remember now, this is the posterior wall. Here's the apex. Here's the anterior wall. More the septum, excuse me. But once again, all of those muscles contract. That is a beautiful look right there. You got nice axial fractional shortening there. You have some nice MAPSI action here. The annulus of the mitral valves moving towards apex. This is a normal study right here. And so almost by accident, well, I'll look at his apical too. I tend to not do that as much as I should. I'm a little undisciplined sometimes, but I look at it. And of course, this is the anterior wall and this is the inferior wall. And I'm curious about inferior wall because he had those Q waves. And so the apex looks great. The anterior wall looks great. But as you come down here, right about halfway down, what's going on here? This doesn't contract and it's a little poofed out. All right. It's a little pouched out, maybe a little bit of an aneurysm going on there. And that's sort of interesting. And when we look at the blood distribution or the coronary blood flow that goes to that area, it's from the posterior descending artery, which goes with inferior myocardial infarction. Here we can compare it to a narrow patient. Right here, this basilar component of the inferior wall does not contract. Right, it's out, and so that should make us pretty darn suspicious that this guy's had a problem in the past. So, of course, what we do is we send him to get cath, and he has a complete occlusion of his mid-RCA, okay? And he's got a 90% occlusion of his LAD. Now, we were thinking maybe that occlusion that he has there in his LAD is why he's getting dizzy and he's getting lightheaded because that's his anginal equivalent. Regardless, he got that stented and went out. Now, remember, this was a guy who just said, I was dizzy. And the next thing we did was send him for a cath a couple hours after he got there. And so this was a pretty dramatic change of course from where we started with a guy who was being seen in our urgent care area because he'd had some dizziness. All right, so that's a pretty interesting case. Let's try another one here. This is a 53-year-old lady, and she comes in saying palpitations. And I know people don't really do that much. They don't come in all that often and say, my heart's fluttering, I'm skipping beats. No, of course, they come in all the time and say that stuff. And like the previous patient, she's got normal vital signs. So we get the EKG as one would for somebody who has palpitations. And when we look at it, this is a rate again of about 70 to 80. We have P's before Q's. The PR interval is normal. The QRS interval is normal. She's got a right axis. It doesn't look like she has a prolonged QT. But it's not hard to miss that there's some funky stuff going on in the precordial leads and the ST and T wave segments. This is all sort of strange here. So I encourage you now, when you see these ECGs, when you see them, hey, get that ultrasound probe out. Go look at these people, see if there's something that turns up. Of course, all of her blood tests and her troponin and all that other stuff are all normal. And so here is her apical 4-chamber view. And I'm just going to let you guys look at that for a second. I want you to think about it. I'll tell you right now, the right side of the heart, That looks pretty good, right? The apical component of the right ventricle should be pointy. It is. We got nice taps. See, we got the annulus of the tricuspid valve. It's moving aggressively towards the apex. That all looks good. But often what I do with my residents and other people that I'm teaching, I said, tell me what's too big. And hopefully all of you now appreciate the left ventricle's too big. All right. It's just too big. And the only reason that things get big in the heart, whether you got a thick muscle or you got a big chamber, is because of pressure. There's too much pressure. And so right now you can infer that there's too much pressure in the left ventricle. It's lost that sort of bullet shape. It's more round and ovular. And also we should notice, hey, that apex, it doesn't squeeze so hot, does it? That is a problem that certainly needs to be investigated in this person who has palpitations. And here we see it compared to the normal heart. You can see this is much more narrow and it contracts and this isn't. And remember, these dilated cardiomyopathies are set up for people who get to get VTAC and other lethal arrhythmias. Sometimes they should get AICDs put in if they're at risk for this sort of thing. And when we look at the coronary artery blood flow distribution for that area, of course, it matches once again with the left anterior descending, and that seems to be the area that's out. Don't get a great look at the lateral wall in this image, but it does look like it's contracting normally. Okay, so what caused this, right? She doesn't have chest pain. She doesn't have shortness of breath. This, based on her history, does not seem to be an acute event. So what caused this? And what I'm showing you here on the left is actually somebody who has an acute MI with the left anterior descending distribution. And notice that the shape of the ventricle looks the same, right? It has that sort of bullet shape, that cone-like shape. And we see right here in the apex, it's normal in size and shape, but it doesn't contract. The basilar component of the left ventricle is contracting pretty well, but we don't have anything up here. This is an apical MI and this is acute. A year later, this is what you get. So over time, that myocardium has sclerosed. It no longer contracts. The pressure starts to build up because your ejection fraction is going down. So you're keeping more blood in the chamber, and it starts to swell, and it gives you an apical aneurysm. And these things are bad because that blood, instead of being pushed out, it tends to sit there and swirl a lot. And sometimes you get clots to form. On the left side is particularly bad because those rascals shoot out, and instead of becoming a pulmonary embolus, they become a stroke or a bowel ischemia. So these things can be pretty dangerous as well, and they certainly should be put on thinners. Now, what's the next step after you see this? And of course, your answer should be, that lady needs a cath, right? We need to see what's going on. And as we would think, she had a complete occlusion of her mid-LAD, and she had a 50% lesion of her circ and her PDA. So again, another patient we were looking at, not thinking, well, this doesn't look acute. I don't think she needs to go off immediately to the cath lab, but she did stay overnight, get cath the next morning, and we found these lesions. So that was very, very important. And again, this is not a patient who came in clutching their chest saying, I have chest pain. I need to go to the cath lab immediately. All right, our next case is again a different case, not somebody who's coming in saying, oh, I got chest pain. This is a 43-year-old guy, pretty young, right? And he had a seizure, and he got picked up by EMS, and he had some altered mental status. He was postictal, and he was coming around by the time he got in, and he had a heart rate of 100 and a blood pressure of 110/70. So not anything too impressive. He wasn't really complaining of anything too much. He had a little bit of a headache because his head had hit the ground a couple of times when he was seizing, but otherwise he wasn't really complaining of a lot. But as part of our workup, we got an ECG. And if you look at it here, you can see the heart rate's about 80. It's regular. They're P's before Q's, so it's sinus. There's a normal PR interval, a normal QRS interval. It doesn't look like he has a prolonged QT interval. And we have an axis that appears to be normal. And so we're looking at all this, and this doesn't really look bad. But I don't know if you picked that up on the top, but the computer said, wait a minute, there's some ST elevation in the inferior posterior lead. So you look at these things and you think, okay, I can buy that looks a little elevated. And I can also say, yeah, we're a little depressed in V1 and V2, and that does go with posterior MI, but the guy didn't have any chest pain. So obviously we see something abnormal. We're going to go ahead and ultrasound this guy. Now, this is the parasternal long axis view. All right. and just look at it for a second, see if you can pick out what's wrong. And just so for the anatomy part, this is the left atrium, there's the aortic outflow tract, there's the right ventricle, here's the left ventricle. And hopefully you picked up that the anterior leaflet of the mitral valve doesn't go all the way up and touch the septum. And that's a nice way to measure left ventricular function. You can get fooled if they have aortic regurgitation, but that's probably the case. And what we can also see, hopefully, is that this right here, which is the posterior wall of the left ventricle, it's not getting short and it's not getting thicker. So this is pretty interesting right here, just looking at this particular view right here. When we compare it to the normal patient, look at this posterior wall. This is normal and it gets shorter and thicker. It's very, very robust. And over here, not so much, right? It's just not moving very well at all. And it does look like there's depressed left ventricular function and a depressed ejection fraction. So here again, we see the distribution for the posterior wall is going to be the posterior descending artery, and that is something that we should be concerned about. Now we move to the parasternal short axis, and right here is the septum, the anterior wall, and the lateral wall. Those all contract. And then down here, the posterior inferior, there's nothing. It's a dud. We don't have anything going on there. So that does line up with our understanding of the blood flow off the posterior descending artery. And here we see it in the normal. Boy, that thing's really moving well. And over here, yeah, it ain't moving at all. There's something going on there. And as we just said before, this area of the left ventricle gets its blood flow from the posterior descending artery. We move on and we get the apical 4-chamber view. It's not the greatest image in the world, but we see enough here to see that the apex of the left ventricle contracts. We got some contractility on the lateral wall, but what we don't see right here, the basilar segment of the septum, it's also a dud. It ain't moving at all, and it really jumps out at you when you compare it to a normal. Look at this area right here. It really shortens and thickens, and over here you got nothing, squadoosh. And so that also leans heavily in favor of this person. We see that this basilar segment of the septum lines up with the posterior descending artery. All right, and this is our apical 3-chamber view. Now, we don't see a piece of the right ventricle in there. We're just getting a piece of it. We're getting the piece we want to see, right? Sometimes it's not about getting the textbook view, but getting to the thing that you want to see. And that's the posterior wall in the apical 3. And once again, it's not moving. It is completely dead. And you can really see that when you line it up with a normal. Look at that posterior wall on the normal and look at this one on our patient. So once again, that is really, really impressive. And it lines up nicely with our understanding of coronary artery blood flow and the posterior descending artery. So all those things taken together, we got a guy who didn't really come in with a compelling story, right? I mean, who goes, oh, obviously he had a seizure, he had an MI. But we saw something on that EKG that got us a little concerned. His trope comes back elevated and he went off. Of course, we have to get this guy cath. He's got 100% occlusion of his posterior descending, and he got a stent placed in there. And he actually did a little better. All right, next case. We're not even going to give you much of a story on this place, almost no history. And what I want you guys to do is try and look at these things and think about which coronary artery is the problem, all right? So the only history you get is chest pain. And here's your first view. So I'm going to let you look at this for a second, see what you think. And obviously, this is an apical 4-chamber view. If we look at the right heart, it looks great. So got a nice pointy apex here on the right ventricle. The right atrium doesn't look big. This really doesn't show any evidence of right heart failure. When we look at the left ventricle, everything seems to contract. It may not be the most robust left ventricle in the world, but everything seems to contract. The septum here, the apex, the lateral wall. And so we don't really have too much to get excited about yet. Let's take a look at a different view. This is your apical 2-chamber view. And we got a little bit of stuff here on the apex. Can't really see the anterior wall very well. But this right here, the inferior wall, It also not moving very well at all, not terribly robust relative to what we would expect in a normal left ventricle. Here we're looking at the parasternal short. We've got pretty good contractility here in the septum and the anterior wall, but everything down here is out. The inferior wall and the posterior wall are out. Also, this is the anterior leaflet of the mitral valve, does not come anywhere close to touching the interventricular septum. So we have what would be considered pretty significant decrease in left ventricular function. Moving on, let's look at something else here. How about this is still the parasternal short axis, but we've moved down from the base arc more towards the apex because here are the two papillary muscles. And we see once again, we have contractility up here, but there's really nothing down here in the posterior inferior segments of the left ventricle. So that is impressive. And now we're going to go back here and look at this parasternal long axis view. And if you really focus here, that whole posterior wall is out. Okay, there's nothing going on there. We have very poor movement of the anterior leaflet of the mitral valve, and we have very, very poor fractional shortening here and almost no MAPC. So this guy has really significantly reduced left ventricular function, and hopefully most of you have come to the conclusion that this guy has a occlusion of his posterior descending artery or right coronary artery. So this is a pretty significant case, and hopefully you've trained your eye a little bit now to look at that and go, oh, this is posterior inferior, this could be right coronary artery, posterior descending, or somewhere in there, and that's where the problem probably is. All right, we're going to do one more case. This is a little bit of an oddball. You got to really think about this a little bit. It'll seem maybe obvious, but there's going to be a twist in the story at the end. And the whole history I'm going to give you is fatigue and weakness. That's what the patient says. Actually, I'm going to give you more. So this is a lady about 45 years old. And she says, just over the last couple of weeks, I'm just so tired. I don't want to get out of bed. I just feel weak, but doesn't complain anything else. She is very sad. Her son had died a few weeks earlier, and she was having some financial trouble. And so that was the only thing. But she didn't seem sad when I talked to her. She was very sort of matter of fact about it. But she said, yeah, I'm just tired. I'm just weak and fatigued all the time. So, of course, we got an EKG, and this is what we saw. She's got a heart rate of about 80. It's regular, P's before Q's, so it's sinus, a normal PR interval, a normal QRS interval, a normal axis. Really don't see any QT prolongation. But boy, there's some stuff going on in these precordial leads. Those ST and T wave segments look really bad. And at that point, her cardiologist, a friend of mine, came over to the ED and said, hey, I just saw it. It popped up on my screen. Let's take her to the cath lab. And his name was Tom also. And I said, Tom, she has no chest pain. She has no symptoms. And he said, really? And I said, well, let's go look at her last EKG and see if maybe this isn't something old. So we pulled up her last EKG, which ironically was 11 days earlier. So if you remember the first one we looked at, it was on the 22nd of August. And this one that we're looking at is 11 days earlier. That's pretty good, right? And when we look at the one from the 11th, we don't see any of those ST and T wave changes. So what happened in those 11 days where she said, I just got tired, but I had, no chest pain to speak of. And we grilled her and said, you sure? And she goes, nope, nothing. So let's get out that ultrasound. And you can see right here, I'm going to let you look at this for a second. But let's go back to the old question of what's too big. And right here, the right ventricle aortic outflow and left atrium should all be the same size. And the right ventricle is a little bigger than the aortic outflow, but the left atrium is really big. So why does the left atrium get big? Two reasons. You either have mitral stenosis, which is rare. It's rare in the industrialized world. Or you have increased left ventricular pressure, which is really, really common, hypertension being the most common cause. In any event, we can see that we don't see full excursion of the anterior leaflet, so we think there's some decreased ejection fraction. And we look right at that dimension there, the axial plane of the left ventricle. We see almost no change in that through the cardiac cycle. So that is pretty concerning for a disease of the left anterior descending artery. So what are we going to do? Let's get another view, see what it looks like. Sorry, it was changing. Oh, before I did that, because of that, I turned on some color flow just to see. One of the other rules I have is when you have a big chamber someplace, go to the adjacent valve. It's almost always going to have pathology. And this is a great case of somebody has mitral regurgitation. So all this pressure that's in the left ventricle is built up, and it's starting to cause this valve to fail in diastole, and that's why you're getting mitral regurgitation. Now, we're going to go to the parasternal short axis. All right, and here we are in the parasternal short axis. And what I'm doing here is I'm moving from the base of the heart towards the apex. And this is the apex here. As you get down to the apex, you can see there's very little contractility, particularly in the anterior wall. It's very, very poor. But this is the base of the heart, and you can see that it looks pretty good. Everything's sort of moving towards the middle. But as you take it and plane it down towards the apex of the heart, it starts to get worse and worse, and you have very little contractility, particularly in the anterior wall. The posterior and inferior walls are moving pretty well, but the anterior wall and the interventricular septum aren't working that well. And that again goes with disease of the left anterior descending. So here we are looking at the apical four-chamber view, and this is the money shot, right? This is the one you've got to think about. And if we go with this rule of what's too big, boy, those atria are huge. They're like coconuts. And they're both bigger than the right ventricle, which of course is abnormal. And they're about the same size as the left ventricle. So there's too much pressure in these two chambers, which should tell you there's something probably wrong at the two atrioventricular valves. We already know that the mitral valve leaks, but we're going to see it again. But now we turn our attention to the left ventricle, and in true to form, that dimension right there, the axial plane left ventricle, has no shortening whatsoever. And we don't get a clean look at the apex, but we can see that it doesn't contract. We have this big, round apex of the left ventricle. So that, again, goes along with left anterior descending. We're going to go ahead and put color flow on the tricuspid valve, and it leaks quite a bit. So there's a lot of right ventricular pressure. It hasn't dilated yet, but she has at least moderate, if not severe, tricuspid regurgitation, which is going to give her an elevated pulmonary artery pressure, some pulmonary hypertension. And then we can also put it on the mitral valve. We know that valve leaks already from the parasternal long axis view, but we again see that there's mitral regurgitation. So given all this information, what would you think is the problem here? And specifically, what do you think the cath report is going to look like? And we looked at all this, and the distribution was the left anterior descending artery. Well, we get the cath report back, and this is it. Here's the right coronary artery, just mild disease. Here's the left coronary artery, left anterior descending, a little schmutz here and a very little schmutz here. This is essentially a clean cath. So what's going on? Well, remember we had said that she'd been pretty sad and that she'd had a lot of things going on in her life. And so we came up with our diagnosis very, very quickly, and that she had Takotsubo. So Takotsubo is the Japanese word for octopus pot, and this is how the fishermen in Japan get octopus for dinner. They lower these pots. The octopus like the pot. They go in there and make home, set up home, and then they get yanked out of their nice existence onto the boat and become dinner. But what's interesting about the octopus pot is that it very much looks like the left ventricle in a patient who has Takotsubo. These are people who have left ventricular failure. It tends to be global, but they have no coronary artery disease. And so they think that because of the sadness they have, there's just like an adrenal overload, and it causes this ischemia, and it causes the left ventricle to fail. Now, some of this is reversible, but sometimes there's a residual deficit as well. So this is Takotsubo, and it's actually more common than you might think out there. I probably see one of these every couple of years. All right, we're done with the webinar, but let me just tell you about our event. So we're about 85 days out from our annual event. We're going to be back in Charleston, South Carolina with our POCUS boot camp, and we're doing co-sponsoring this with Clarius. So Clarius will be there, Shelley will be there, some of the other Clarius folks. They're going to have Clarius equipment. You're going to get an opportunity to use these things. Heck, you can buy one and go home with it and start using it the next day if you want. It's really going to be a lot of fun, and just a fantastic opportunity to just dive into a bedside ultrasound POCUS. Now, a lot of you will probably have CME money, which ends at the end of the year. This is a perfect use for your CME money. And you're getting great CME. You get 16 hours of CME. You're getting to learn great stuff. The people who come to our courses watch every minute of it because it's just really interesting. We're going to dive into some cool stuff, resuscitation, a lot of cardiac stuff, a lot of critical care stuff, some procedural stuff. We'll be looking at placing lines, both peripheral and central lines with these Clarius systems and all the different ways we go about it at our facility. So this is a lot of fun. Well, and it's an opportunity to really change the way that you practice medicine. So if you want to do the full dive, I know a lot of people here rarely use or just learning. This is the way to dive into this technology. And seriously, you could start using it the next week and just totally change the way you do things over the next several months. So it's a really cool opportunity to get up to speed very, very quickly. As for Charleston, it's one of the top 10 tourist destinations in the United States. All of these homes are several hundred years old. They've all been restored. Incredible number of restaurants and boutiques and shops, lots of things to do. If you have children, there's an incredible aquarium in town. There's lots of things for children to do as well. So you can bring your family if that's an interest. And November in Charleston in South Carolina is incredibly nice. We have very mild temperatures, a great change of color. Fall is quite beautiful in my state. We'll be staying at the Hyatt Place Hotel. This is a fantastic venue. We've stayed here many times. There are suites available if you want to bring your family so you can have a full kitchen. Another thing, and the conference facility is adjacent to the building, so it's fantastic. The way you sign up is to go to our website. This is either emergencyultrasound.com or thirdrockultrasound.com. You can hit this QR code right here, and it will take you to the website. If you want to take a screenshot of that, you can. It'll take you directly to the website. We're also offering for the first 10 people, that's it. There's a discount code for 25% off, 25% off a registration. The discount code is called BOOTCAMP24, capital letters, uppercase letters, BOOTCAMP24. And so if you get in there, you're one of the first 10, you'll get 25% off of the registration fee. If you have any questions about the course or anything in this webinar, you are more than welcome. I would love to hear from you. The email address is thirdrockultrasound@icloud.com. Third is spelled out. It doesn't have the number 3 in it, so just be aware of that. Maybe get a screenshot of that as well. Final thoughts, and then I'm going to turn it back over to Shelley. So what we're trying to do here, of course, is match the wall defect, the wall motion defect, to which coronary artery is there. And it may seem a little complicated at first. This is not the easiest thing to do, but it doesn't take much. If you're seeing older patients, sicker patients, they're all over your ED or all over your practice. They're there. They're very easy to see. It's just a matter of training yourself to see them. Sometimes you have to compare them to normals, but you'll get it. And it's just a matter of practice, like anything in life. If you do it, repetition is the bane of learning. So this is certainly not impossible. I can learn it. Pretty much anybody can. And that's it for the webinar. I thank everyone who has listened to this. I'm going to come back later and answer any questions you have. And right now, I'm going to turn this back over to Shelley.
Okay, I have a model that I'm going to scan his heart with the Clarius PAL, so the phased array and linear. And I'm using the phased array component. And I've just gone into the eFast preset and I've just selected the cardiac icon. And this is going to get me my cardiac imaging. And I'm going to start off at the apical view and turn my gain up a little bit here just so that we can see the walls really nicely. And yeah, so nice view of all 4 chambers here. So we can really get an idea of how well the walls are contracting concentrically. We can look at the size of the chambers as well. And then to get the 2-chamber view, I'm just slowly rotating the scanner 90 degrees counterclockwise, and we are going to just now see the 2 chambers of the heart. And this one sometimes is a little tricky because the ribs get in the way, but it's just a little bit of finesse movement. And there we go. So we can see the inferior wall here, the anterior wall here, and sometimes we don't see it when there's respiration, but if we just wait, or we can get our patient to take a small breath in and hold it, just a small one. Yeah, sometimes that helps move things into a better view. There we go. Good, breathe. And then if I rotate just even a little bit more here, we're going to get that apical 3-chamber view. Right, so aortic outflow tract, aortic valve, mitral valve, septum, and posterior wall here. So once we're done having a look at that, we can go up to the parasternal window. And nice valve motion, nice contractility of the posterior septal walls. And then we can just point down to the apex to see that a little bit better. And then again, just rotating counterclockwise. And here's the left ventricle at the level of the mitral valve. And if I point the scanner down toward the apex, we can get down toward the apical view. So here's those papillary muscles. Here, so nice concentric contractility. I like this view because you can see all of the walls at once and you can kind of compare them to each other. And I'm just going to jump over a rib down a little bit further so that I can get closer to the apex here. And now we're right down at the apex. So there, in a matter of a minute or two, we've kind of done a fairly thorough assessment of the wall motion. All right, good. So please stay on if you have questions. We're running a little behind, but if you have questions, we'll certainly answer them when we're done. I just want to invite you all to take one last poll to let us know if we can provide any further information about this Clarius wireless ultrasound. And please click on as many options as apply here. And while you do that, I'll just tell you a little bit more about Clarius PAL HD3 dual array wireless scanner for whole body ultrasound. As I showed you, it has an innovative dual array wireless design that fuses a phased array and a linear array on a single head, so making it really versatile. It stands out by offering the broadest frequency range at 1 to 15 megahertz, making it ideal for clinicians seeking versatility, image quality, and diagnostic flexibility. Clinicians say they can perform 95 to 99% of bedside exams with a single scanner, eliminating the need to swap probes, reducing interruptions, and improving your workflow. With Clarius, there's no wires to get in the way to infect your sterile field. And the scanner is IP67 rated, waterproof, and fully submersible for disinfection. It's lightweight, ultra portable, has a 0 footprint, and features the latest antenna technology for the most reliable direct Wi-Fi connection to iOS or Android phones and tablets. And with no wires or bulky carts limiting monitor placement, you can easily share real-time imaging and talk patients through their exam, fostering engagement. Clarius scanners include a complete ecosystem that includes an easy-to-use app, and available with our membership, exam management is easy as well. Seamlessly save images and videos to your PACS servers through current DICOM web standard, or use Clarius Cloud to securely capture and manage unlimited exams from anywhere. Your membership also includes Clarius in-app videos with experts like Dr. Cook and onboarding with the clinician. And Clarius Live delivers one-click telemedicine if you'd like to share live scanning with a colleague for a second opinion. Now, we have an exclusive offer for webinar attendees here. We're offering discounts on scanners as well as software. So you can take advantage of these savings using this QR code. And you have about a month to claim this offer. And as Dr. Cook mentioned, the course that we're going to be offering and 2 days in Charleston, South Carolina. I'm so excited that I'm going to be there. So I hope to see you all there as well. Great. So I think that's it. Dr. Cook, I will welcome you back to answer questions. And let's just see what we have here. Okay, so the first question, it's difficult to palpate pulse with a patient in cardiac arrest. If the patient is in PEA, do you agree use of cardiac ultrasound can be used to actually see if the heart is contracting forcefully despite not feeling a pulse?
Absolutely. We just did a big session. We just reviewed a paper on this at Journal Club last week. It was a very long, exhaustive one, but yeah, that's exactly the point. I can't tell you how many times I've been in a code and nobody can feel a pulse, and I'll look, I said, the heart's beating, It's doing what it's supposed to do. We just either need some volume or some pressors. Usually when we get that situation, we try and figure out what will quickly give us a little bit of pressure, whether we're going to give them some levofed or maybe some vasopressin or something like that to try and get some pressure. But in PEA, it's absolutely critical to use our ultrasound. The two times you don't want to do ultrasound first is when you have something that's shockable. So if you have pulseless fib, pulseless VTAC, or something like that, that's the time that you should be giving them electricity before anything else. But most of the other things that you're going to deal with, in particular PEA, you want to do ultrasound first. And there's other things you can find, right? Like if you get a big right side of the heart, this is probably a pulmonary embolus. If they have a pneumothorax, that's somebody who needs a chest tube or chest decompression. But yes, we do it all the time. And it's part of actually what's considered to be state of the art right now.
Great. Someone here has a question about case number 3, the lady with the palpitations. Why would she have a negative trope?
Because that infarct had happened a year earlier. That's why she had that big apical aneurysm. And so she was not an acute MI. She was a person who'd had an MI at some point in their past, never got seen. And sometimes when you talk with these people, they'll give you a very interesting story. It's like, oh yeah, a couple months ago, I had this terrible indigestion. I had all this burning and I couldn't get comfortable. And then I felt terrible for a few days. They just had their MI and didn't seek care. And it's only later on as the heart starts changing shape, right? And remember, she had palpitations. So because her heart had changed shape, she had a dilated cardiomyopathy now. She was probably getting runs of VTAC. And those big dilated hearts, those are the ones that get ventricular tachycardia. So that is why she had a negative trope.
All right. How helpful is this with pericardial effusions and RV strain?
Fantastic. So we've done previous webinars. They might be on the website someplace. I'm not sure.
They are. Yeah.
And so again, this is state of the art for pericardial effusion diagnosis and draining them if you need to, if this patient's really sick. And then right heart strain, again, for large pulmonary emboli, this is critical to use this technology. And also we're discovering quite often that we have a lot more pulmonary hypertension than we think we do. And this is a very difficult disease to treat, but if you catch it earlier, the patients do much better. And these will all be things that we'll be covering in Charleston in depth. So we can really give you a super strong foundation of information, going forward if you're interested in joining us.
Great. And I think we'll just have time for one more here. And we will follow up with answers to your questions if we don't get them to them during the webinar here.
Yeah, I answer all I get a list of emails, so list of questions. So please send them and I'd be happy to answer them.
Great. Okay, so one more. Can you just clarify how to get the 3 and 2 chamber views from the apical 4 chamber view?
Yeah, so when you're in an apical 4, your marker's going to the patient's left. And if you just hold that position in 4 and then gently start turning the transducer, counterclockwise. And so at some point, the orientation marker will be sort of pointing at the patient's head or maybe pointing directly away from the body. And then if that will give you a 2, and then you continue counterclockwise and you'll roll into a 3. And it's a little bit of a finesse exercise. Again, that's something where if we're working with you live and we can hold your hand and walk you through that motion, it makes it a lot easier. But as with anything, it's really about practice and repetition. But if you can't come to see us, find somebody who knows how to do it. But we'd certainly love to be able to show you that maneuver. Yeah.
And I find too, like if you can keep your eye on the screen while you're rotating the scanner, you can see the walls coming in and going out, and it makes it easier instead of like starting from scratch. lifting the probe and then putting it back on. Just keep the probe on the patient and as you rotate. And I find that really helpful as well. Awesome. All right, good. Well, we are just past the top of the hour, so I think we will call it here. So thank you all for your questions. And as I mentioned, we'll get back to you. Thank you for completing the poll, and we will be sending out a PDF copy of the slides as well as a webinar, a link to the webinar recording, so you'll be able to watch that at any time. So keep an eye on your inbox. I'd like to thank you, Dr. Cook, for sharing your best practices, and a very big thank you to all of you for joining us. And I encourage you all to complete our closing survey so that we can continue to bring you educational webinars like today's. So thank you again, and until our next event, keep scanning. Bye for now.